Let's talk about another diuretic called acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor. It causes self-limiting sodium bicarb diuresis, meaning sodium is going to go out, bicarb is going to go out, and decrease in total body bicarb stores. So when you decrease the bicarb, or when you throw the bicarb out, what you're causing is that's going to be acidosis. Bicarb is basic. When you're throwing out the base, you're causing acidosis. So if you look at the adverse effects, we have this acidosis. Okay. It alkalinizes the urine. Because let's talk about this way. So there are two effects. One effect is within the kidney or within the tubule meaning urine, and one effect is in the body. Okay. So when the carbonic anhydrase, actually let's draw how the carbonic anhydrase, since they haven't have the image here, they don't even have the image here, so let's just draw it. So it is acting on the PCT, okay, in which you have, let me zoom in which you have, so this is, let's just say this is lumen membrane, meaning urine. These are the, let's say these are the cells, and then you have this one, which is the basolateral membrane, meaning blood. Luminal membrane, they can also mention it as apical membrane or tubular fluid. Basolateral can also be mentioned as interstitial or interstitium, which is basolateral, which is basically blood. So let's just have this here now. Okay. So normally we have the bicarb here in the urine. That bicarb gets a proton. Okay, when it gets added with a proton, it forms H2CO3. Where did the proton came from? It came from the channel called sodium proton antipotor. So the sodium is going in, meaning going into the blood. The proton is going out into the urine. This is urine, remember? Okay. So this is, we formed H2CO3. That H2CO3, the carbonic anhydrase, which is present here on the epithelial cells, that convert H2CO3 into CO2 plus water, and they easily go back in. So why do we need all of this? The question is, we can't reabsorb bicarb on its own. So we need to convert it to water and carbon dioxide in order for it to freely get reabsorbed. So when it gets into the cells, let me erase this big line. When it gets into these cells, again this water can either go back to blood or can stay in the cells. And if it does stay in the cell, again we have this carbonic anhydrase enzyme that acts on this and makes it hydrogen ion and bicarb. Now this bicarb, we can reabsorb the bicarb to maintain the pH of the body, or if we have enough, we can leave it here, and that H is just going to go out and again form the same cycle. I hope it's a little clear, but let's now do the pharmacology. So when we inhibit this carbonic anhydrase and carbonic anhydrase, guess what? We cannot form this, and we cannot form the hydrogen. So we are left with this thing going out in urine, right? It goes straight out. That bicarb goes straight out in urine. So that is what they're saying there. Let me erase this and show you. It causes self-limited sodium bicarb. So, but you got the bicarb idea, how bicarb is going out. So let's talk about sodium here. So because we are not forming this hydrogen here, which was normally going out, so we can't even reabsorb sodium, because we need this hydrogen to go out in order for the sodium to come in. But we don't have this. When we don't have this, the sodium cannot come in. So sodium also remains outside. So that sodium and bicarb go straight in urine, diuresis, which leads to decrease in total body bicarb stores. And then when you have so much bicarb within the urine, it causes alkalinizes the urine, right? Increases the pH of urine. And what is the thing that we talked about? When you increase the pH, you can develop stones. I don't know if they mentioned that. Promote calcium. Here, look at this thing. That increased pH would cause stones, calcium phosphate stone formation, which are insoluble at high pH. So this is the mechanism of action of carbonic anhydrase. Let's talk about the clinical use now. We can use it in glaucoma. We can use it in metabolic alkalosis. What is metabolic alkalosis? Well, one of the adverse effects of this is causing acidosis. So we are using it in alkalosis to cause acidosis. We are using it in alkalosis so we can throw off all of the base in urine, so the body can become in acidosis, or becomes neutral in pH, or opposite of alkalosis. We can use it in altitude sickness by offsetting respiratory alkalosis. Now in altitude sickness, what's really happening? I think we also need to talk about this thing. In altitude sickness, remember, when we go in high altitude, we have decrease in the partial pressure of oxygen in the atmosphere. That would decrease in our PaO2. The air is low. When the air is low, we are going to develop hypoxemia, right? And that hypoxemia would develop. Let me zoom out. That hypoxemia, and remember the rule of thumb for the lungs. Whenever there is a hypoxia in the lungs, the lungs, those vessels will vasoconstrict in the lungs, and while in all over the rest of the body, whenever there's hypoxemia or low oxygen, the rest of the body vasodilates. Hypoxemia here is going to cause vasoconstriction of the lungs, and secondly, we are going to go into hyperventilation. When we hyperventilate, we are going to throw out the carbon dioxide. When we throw out the carbon dioxide, which is an acid, when we throw that out, it causes alkalosis, because we're throwing out all of that acid. Alkalosis. Now we name it respiratory alkalosis because due to the fact that because we are hyperventilating, which is throwing the acid out, and it is the respiratory problem. That's why respiratory alkalosis. So that's what it says right here, respiratory alkalosis in altitude sickness. So we can give acetazolamide that is going to be used in the altitude sickness for the respiratory alkalosis. Okay. Now the next thing is the idiopathic intracranial hypertension. Intracranial hypertension, we're just decreasing the volume and getting the intracranial hypertension down. That's the mechanism behind that. But moving on with the adverse effects, what do we have? We have the proximal renal tubular acidosis. Again, it's acidosis at the proximal renal tubule, type 2 RTA. Remember just the acidosis. Paresthesias, NH3 toxicity, sulfa allergy because it's a sulfa. All of the diuretics are sulfa drugs, except like the loop diuretic, thicurinic acid. Otherwise, all of the diuretic or sulfa containing drugs. So can lead to sulfa allergy. And what is the sulfa allergy? Well, the sulfa allergy is when you have the sulfur group within a drug. Why do we add sulfur? Because it's a lipophilic thing which will cause the drug to go everywhere. Sometimes, because it's so lipophilic, the proteins attached to it. When the proteins attach, you can cause allergy, and that's the hypersensitivity reaction can develop against them, leading to sulfa allergy. Can cause hypokalemia. Okay, promote calcium phosphate stone formation. Okay, that's we talked about calcium, how because of the pH, high pH, how it can cause the calcium phosphate stone formation. So I guess that's pretty much all for acetazolamide.